panel discussion. This is view from the cities, and we have 8 cities which are participating: Mumbai, Varanasi, Vijayawada, Kolkata, Bangalore, Aizawl, Rajnandgaon, and Srinagar. We have the pleasure of joining us on this panel, Mr. Suresh Kakani. He is Additional Municipal Commissioner from MCGM. Mr. Sujit Pateja, he is Director, Smart Cities and Urban Governance, SAP India, in discussion, along with Dr. M. Ramachandran, Distinguished Fellow, SKOCH Development Foundation and former Secretary Government of India, and Dr. Shefali Das, SKOCH Foundation and former Director General, National Informatics Center. And to start the discussion, I now have the pleasure of inviting for the opening remarks, Mr. Sameer Kochhar, Chairman and Founder of SKOCH.
Thank you, Gursharan. When our health system was under turmoil and so many things were in short supply, it was a supply chain problem, it was a logistics problem, it was a coordination problem, it was a governance problem of unparalleled proportions. It is then that our civil servants from across the third tier of governance, cities, Panchayati Raj institutions, even districts, rose up to the occasion and made sure that these things are no longer in short supply, oxygen is adequate, beds are adequate, medicines are adequate. And now we see that because of all that effort, the second wave is behind us. However, the battle is not yet won. And then there is an impending third wave that we all have to face. Since morning, we've heard of a lot of models. Most often repeated model has been the Mumbai model. I think there's a lot of learning for everything else. Also, it is not as if what Mumbai has done would have been a piece of cake, or what they're going to face further is going to be easy. So what is it that they have learned from the second wave? How did they surmount that challenge? And more importantly, keeping that learning in mind, how are they planning ahead and looking at planning for the third wave is the most important conversation that perhaps we can have this afternoon. It is my pleasure to invite Mr. Suresh Kakani, Additional Municipal Commissioner from MCGM, to share his perspective on how Mumbai, what you have learned, and how moving forward Mumbai is planning to tackle the third wave.
As you rightly said, that a whole lot of preparation that Mumbai is going through while seeing that an impending third wave. So even Mr. Kakani has been pulled into something, and he has requested Dr. Daksha Shah, the Executive Health Officer, to make this presentation on his behalf. Dr. Shah, please unmute yourself.
Can you hear me now?
Yes, please.
Yeah. So thank you, Mr. Gursharan, Dr. Gursharan, and Mr. Sameer. I first apologize on behalf of Mr. Kakani, sir. He's been engaged in something, and I'll be presenting on behalf of him. And I thank the SKOCH team for inviting MCGM to present this model. At the outset, I would also like to thank the entire team of BMC and all our officers, all medical, paramedical staff, innumerable people who has been putting massive efforts in controlling COVID in Mumbai. So I have a small presentation to make, and I'll share my screen. Can you see the screen?
Yes. Your voice is a bit muffled.
Okay. Now can you hear me? I think I'll have to speak louder.
Yes.
So when we are talking about the Mumbai model, there are a lot of strategies, there are a lot of concepts, and there are a lot of work which has been gone into developing this model. And now we are pretty confident in controlling and planning for the third wave. So just to set up stage right, just a small glimpse of Mumbai demographies. Of course, we have 12.5 million population, and a lot of floating population. There are a lot of complexities in the city, and our vulnerability is very high for any pandemic or the disaster. In fact, the vulnerability index, which is published recently in the Lancet, we have a very high vulnerability for the outbreaks as well as demographic vulnerability. Population density makes us what is, gives a lot of ingredients for spreading such disasters. We have a three-tier system of healthcare in the city, and this is the BMC healthcare, the primary, secondary, tertiary. Extensive healthcare system is there. There is primary health centers, there are dispensaries, and there are a strong force of primary health workers. We call them as CHVs, who goes house to house in the slum areas and motivate people and get the healthcare messages across to the community. We have a secondary healthcare and we have a tertiary healthcare, that is the 5 medical colleges, and we have a huge private sector. Around 1,500 odd nursing homes and hospitals, large independent practitioners, and other government entity hospitals. So when a disaster or when a pandemic like this requires a lot of coordination and collaboration between all these across the systems. If I have to just summarize the pillars of the Mumbai model, then one is the readiness of the system, the aggressive prioritized testing and tracking, the rapid expansion of health infrastructure in a very short period of time, micro-planning the oxygen supply, war room and decentralized bed management, private sector engagement, community participations, legislative measures, and transparent messaging. Somebody has mentioned about the social media and the use of effective media. We have actually strategically used the media very effectively in our control. And of course, use of data and strengthening the systems. This has all been placed very well, and there is a good mix of this, and overall arching is the governance and the leadership. So if we talk about the Mumbai model during the second wave, we were at the advantage because we had already handled the first wave. And we had some kind of lessons which was learned, and there were strategies. So there was some kind of intelligence was there in the system. We were studying the trends of the other countries, and as soon as the UK and the US started reporting cases, we had strengthened our operations at the airport. We had placed in the airports the surveillance of the international passengers. In fact, we were the only city who made it compulsory that all the international passengers are quarantined in a hotel, and on the 7th day we would then test them, and then we will allow them to the home isolation. So we were very vigilant from the beginning in the month of January itself. We never closed down our jumbo centers, which was been put up during the first wave, the field hospitals in Mumbai. And this was sustained, and this was also very helpful during handling the second wave. And we had a real-time monitoring, a big IT system, strengthening of partnership with the private sectors. I think private sector was very important, involving them. Not only involving them, but regulating as well as developing a relationship with private, so that there is a sense of ownership in the private sector. This was an also important strategy which we had adopted. Clarity regarding various institutional mechanisms like procurement operations, HR operations, and the mitigation operations. So these all were detailed micro planning was made, and there was SOPs which was being laid down. So there was an institutionalization of so many operations. And then confidence building was already there in the treatment and the clinicians. And last but not the least is the community participation, multi-stakeholder involvement, and staff motivation. First pillar which we have described is aggressive testing. Now, from the beginning, we have been partnering with the private labs. We have around 80 plus private labs in the city, and coordinating with all these private labs, getting the reports from all these private labs on time, and giving them some targets of reporting to us even before they share the report to the patients was very important. So we have a whole team who's working with the lab, and we have a continuous surveillance which is happening. Even the whole genome sequences we have already started. So we are continuously monitoring the test positivity. Initially, we began with a testing of say 100 tests per day in 2020. Then we went slowly up to 20,000, and in February we went up to 50,000 tests. And there was this strict turnaround time targets which was given to the lab, and the RT-PCR and the RAT ratio, as per the government guidelines, we have been observing that also. We have focused testing with the patients and the context, but in addition, all those malls, railway stations, tourist spots, all these places, the testing is going on, and there are extra teams which has been put up. We have 284 spots in the city where we have a walking testing and the kiosks which has been organized, and there the RAT test has been also offered. And most of the wards, as we have said, that the Mumbai has 24 wards. All these wards have the testing centers in the dispensaries as well as in the ward offices. So everybody who can walk in and they can get the test done. And these are being offered free of cost to the citizens. The next pillar is, of course, the rapid expansion of the health infrastructure and including the private sector. We can see over here that in the month of February compared to April, we have expanded our COVID beds, our COVID facilities and ICU beds compared to the February in the April 21, almost 50 more times. The COVID centers we have kept, which was in buffer, we have reactivated it, and 60% of all the beds were converted into oxygen beds. Now, ensuring the medicines were also very important. Remdesivir, enough stock was been procured, and Tosi and so many other medicines. In fact, for the mucormycosis also, we had a very systematic, allocation of mucormycosis medicines to the patients. We have created a committee who decides based on the notification of the mucormycosis cases. So we have a Google spreadsheets where every hospital reports the mucormycosis cases and they are then allotted. As I said earlier, the private hospitals was engaged systematically. There was a commissioner who himself takes the Zoom meetings with the private CEOs, and all are given detailed SOPs of how to accept the patient. So all these 80-20 schemes, you might be knowing that the state of Maharashtra has this GR of 80-20. That is, all the private hospitals isolation beds, 80% of the isolation beds and 20% of their ICU beds would be under the control of BMC. That is, they will be allotted only and only through the ward rooms which we had created. And also the charges were fixed. So having this circular and then the implementation machinery which was also made into place. So this was once again made functional during the second wave. And then what was important was creating the step-down facilities because a lot of patients who then become, I would say that those who have recovered or partially recovered, they would not require an ICU bed. So they have to be shifted to a step-down facility. So there was a timely decision taken to shift these patients to some of the hotels which was being designated. And there were clear SOP which was there between the hospitals and the hotels, like how do patients manage for monitoring during the rest of the period when the patient is recovering. So all this has led to freeing up some of the beds and increasing our capacity. So in the month of February, we had said 13,000 beds. We had gone up to 22 and even 30,000 beds at the end of April. And we saw the surge of cases in the month of April. Now, during the first wave, for the entire period till December, Mumbai had reported around approximately 3 lakh cases. During the second wave, in the month of March and April and May itself, we have somewhere around 3 lakh cases. So it took almost 270 days to reach to 3 lakh cases during the first phase. But during the second wave, it was hardly 60 days which we reached 3 lakh. So even the active cases which increased to tremendous numbers. From 30,000 active cases in the first wave, we had to manage 90,000 active cases during the second wave. And that was a huge load on the system. So in addition to this, as we know, the 60% patients are managed at home. So the home isolation programs were instituted. There was a systemic involvement in external outsourced agency who would then have the IVR calls every day to the patients who are in home isolations. In addition to our primary healthcare team, also would then follow these home isolation patients, and there were protocols and when to patients and whom to contact. These all were explained to the patients. Now, coming to the oxygen management, I think this was one of the very important pillar of our Mumbai success during the second wave. There was a very detailed micro planning and the teams which were created. There were 4 levels of team which was there. One is a hospital team, crisis management team, the core team which constituted, of course, the additional commissioners and the engineers. And then there was a government of Maharashtra and FDA team. Now, all these teams had coordinated for the ensuring that oxygen supply is proper during the second wave. The hospital team, headed by the dean and the head of the departments, would ensure the rational use of oxygen, lowering the goals of the oxygen, not the 100% to up to 93 to 95%, ensuring that high flow nasal oxygen is used only under the supervisions, oxygen nurse and oxygen boys, so that there is no wastage of oxygen. And of course, the monitoring and the audit by these hospital teams is continuously going on. Crisis management team is ideally for, estimating the crisis and demand. So all the private hospitals, public hospitals had to put their whole data of their oxygen situation into Google spreadsheets, and that would be monitored by this crisis team. There was a zonal assistant commissioner and deputy commissioners and the medical officer as well as engineers who are continuously monitoring and networking with the hospital to get the real-time data. And the hospital has to flag an SOS 12 hours before their oxygen is to end, so that there could be a management of the oxygen which could be done at that level. And this was working 24/7. And then comes the core team who were also continuously supporting the ward team. There was this oxygen supply chain management. We had estimated around 275 metric ton of oxygen requirement of entire BMC, and there was a detailed calculations of moderate patients and severe patients, how much oxygen will be required. So demand calculations and then resource mapping of the tanks, and as well as the refilling of cycles, and how the supply would go, what are the transport, what are the points, how the mapping will be done. All these was done by the core team. And for that, we had also had this inventory mechanisms and increase in the storage capacity by procurement of additional cryogenic tanks and so many so forth activities which was undertaken. Currently, we are having 5 oxygen generation plants which has been installed in Mumbai. And not only that, in addition, we are having our own oxygen refilling, Dura and the jumbo filling plants, which has been now getting started in Mumbai, so that the oxygen, for the filling of the oxygen cylinders, we don't have to go a larger distance. So this overall planning, the micro detail planning by the various engineers as well as the honorable commissioners, detailing, has helped Mumbai to overcome this oxygen crisis, which many other cities have faced. And next is, of course, the ward room. Now, this ward room structure, which was been well discussed, it was also been well, appreciated in the media, that what is important is to reassure the patients that he will get a bed if he needs. So for that, these ward room, which has been created in way back in June 2020, we re-energized and reactivated this ward room during the second wave. And these ward rooms are basically manned by the medical and paramedical staff, and their functions, you can see here, is the triaging the patients, allotting the beds, ambulance connectment, and the vaccine guide, as well as connecting the traces. So it is kind of a one-stop shop for all the solutions for the patients who they are looking out. Decentralized bed management was one of the very important pillar of our management of second wave. And during the second wave, this was the process which was been defined. I'm specifically, showing the process how we did it. So these 24 ward rooms which was there, they were working in 3 shifts. There were detailed SOPs. There were coordinators were appointed at the facilities as well as at the ward rooms. There were adequate staffing which was been done. There were 30 hunting lines were given, 10 teams were created, and 10 ambulances which given to each ward room. Now, these ward rooms will continuously be in touch with the patients. We had a process flow, you can see it on the right side. We had this labs, as I said, that there are 80 plus labs in Mumbai. They would put this whole positive patient data into the ICMR portal. This will be then downloaded by our IT team, and they will deduplicate these patients, as well as they will allot the wards to these patients, and the whole line list will be shared and to each and every ward pertaining to those patients. And this will be the whole work which will be done overnight. And after that, at 6 o'clock in the morning, the ward will have the ready-made line list, and then the ward will start. This ward room team will start calling the patients. They will triage the patients, and they will assess which patient needs the bed. So asymptomatic, symptomatic, ICU. So this assessment will be done by this ward room team. And after the triaging, a team will go to the patient's house, and they will then shift the patients in ambulance after assessing the patient condition to the hospital. So this whole mechanism, they will then finish it by 5 p.m. the same day, the entire number of patients line list which has been done, and there will be patient. So like this, this decentralized bed management was the game changer for Mumbai. So patients don't have to run pillar to post in search of the patient, in search of the beds. What was also important was a dashboard. A dashboard was created including all the health facilities. They have to update their beds every 4 hourly into the dashboard, and then this dashboard will be accessed by the ward room team, and then accordingly they will see where the beds are, and they will allot the beds. So this whole mechanism was working very well in the second wave, and that is why I think we could manage such a large number of patients, their allotment of beds, and ensuring each and every patient gets the bed. And there was this strict guidelines of allotting the beds, in which sequence which beds will go. And also the private sector hospitals were clearly informed that no direct admissions of the patients will be allowed, no asymptomatic patients will be given the bed, and there was cross-checking by our team of auditors also, which was handled simultaneously. There was this central disaster cell, the unit which is well established in Mumbai. They were also coordinating this entire response, the 24 ward rooms and the hospitals. So this was the essence, I would say the time was the essence, and decentralized bed management model, which was also a game changer during our second wave management. you can see the trend of COVID cases and deaths and the CFR in Mumbai. We had during the second wave, there was April and May, we had the maximum cases. The cases started rising from the February, and then it went at the peak in the month of April, on around the second to third week of April, and then it started going down. But however, we could manage to keep the CFR low, below 2%. You can see over here that how the CFR has come down. And this was also due to the another mission which we had launched, is a mission Save Lives, and under that, the detailed SOPs were again given to the hospitals, that what are the steps that the hospital should take to save lives, to focus on the patients, and every death was audited, and the few steps were taken that if you can prevent the deaths in certain cases, how the improvement of the system is required. Having said all this, the second wave, we have learned many lessons. I have specifically highlighted some of the functions and some of the strategies. Now, this strategies is of course there in the place. Now, building on that strategies, the third wave preparation is already on. So one is of course the aggressive vaccination which is going on in the city. Then pediatric task force. We have seen that continuously there is some rise which has been seen in the pediatric cases from the month of February till now, from 5% contribution of the pediatric cases, which has come to 9%. So there could be some rise in the pediatric cases during the third wave. So we have prepared our pediatric task force. Capacity building, extensive capacity building and SOPs has been circulated, like which kind of pediatric cases to be managed where, by whom, and what are the treatment options and guidelines. These all has been put into place, considering the pediatric surge. New jumbo facilities has been now planned and has been started in Mumbai, considering that the third wave will come very soon, probably by end of say September or maybe July. So there are a lot of predictions, a lot of modeling, a lot of calculations which is going on. So based on that, we have certain estimations where the new jumbo facilities is now being put up. Additional oxygen plants, as I said, has been just inaugurated yesterday. We have 5 new plants in terms of self-sufficiency to achieve in oxygen we have already installed. Strengthening of the surveillance has been there, because as soon as we know that there is opening of the economy, there are restrictions which has been raised, the people become lax, the behavior becomes little, COVID appropriate behavior goes haywire. So again, we have strengthened our surveillance, appointing the new HR and outsourcing the HR, a lot of operations we have done that, and preventing the super spreader events. So for that, all the restrictions and the break the chain transmission we have done. So I would just like to highlight some of in details. So strengthening the surveillance activity, we have this break the chain orders which has been issued by the government of Maharashtra, and there are levels which has been decided based on the test positivity and oxygen bed occupancy. Right now we are in the level 3, and from most restrictive levels to the most relaxed level, we have 5 levels in the city. But in the in break the chain orders, we have decided to be, the commissioner have decided to be in the level 3, and of course every day, every week this is being assessed. Then we have identified the high risk ward daily. Right now in the third wave, it is very important to closely monitor this number of cases from which wards. We have 24 wards, and we have hotspots mapping which is happening, and where is the clustering happening, and accordingly the camps and the focus activities has been done. We have an eye on our various variant of concern, especially the Delta Plus, and there are samples which has been sent to for the whole genome sequencing, and we are also preparing our own lab to have this whole genome sequencing testing, which will be done in our own lab. Then there is this increasing targets which has been there, different sections of the society. We are placed the kiosk which I've shared earlier. And there is this contact tracing which is 100%, and based from the 5th day they have to be tested, and they are followed up for 14 days. And there is strict adherence of guidelines for the international travelers and the passengers, and the whole genome sequencing as I shared earlier. So we are strengthening, and we are having continuously watch on our containment as well as our tracking and testing strategies, how it is implemented in the field. As I said, the augmentation of the infrastructure. We have now 4 jumbo facilities which has been planned, 7,000 beds total, 6,000 oxygen and around 1,000 to 1,500 ICU beds, which has been now proposed, and one already has been inaugurated in Malad with 2,000 beds. We have special beds for the pediatric population, so 400 COVID beds capacity has been planned in the NESCO, one of the field hospital, and a special till CCC2 for in the maternity homes for the children and the parents admissions also been planned. And all these 4 jumbo facilities which is going to come up, we have spatial operation and management through outsourcing. So we have just floated an expression of interest for whole management of these jumbo facilities, depending on what all the private partner will bring on board. We have floated this expression of interest. And then as I said earlier, the pediatric task force at the city level, we have the pediatric task force and the state level. And we have the Indian Academy of Pediatric, all the pediatric members who have been sensitized, and we have n number of workshops which has been conducted. Every ward has conducted the pediatric, and there was a good coordination between the municipal centers as well as the private pediatrician has been established. And there are multiple trainings of the grassroots workers, especially the ASAs and we call it as CHVs, and Anganwadi workers and medical officers. And this has been conducted in the month of June itself. So the capacity building to handle the pediatric surge has also been developed in the city. Now, I would just like to add some few points about the vaccine coverage in Mumbai. At the moment, we have around 300 plus vaccination centers in the public sector and 94 plus in the private sector. And till date, we have vaccinated around 43 lakhs first doses, and we have given 10 lakhs plus second dose, so around total 53 lakh doses has been given. We have the capacity of doing at least 2 lakh vaccine per day if the sufficient quantity of the vaccine is available. And we have several other initiatives which we have taken to improve the coverage. We have given approvals for the private hospitals and the private entities to conduct the camps. So private CVCs has been approved. The workplace vaccination has been started, and there are protocols and the SOPs which has been laid down for the workplaces to undertake the vaccination drive. And near to home vaccinations, so we have 227 municipal councillor areas, and every area we have started one vaccination center. So near to home vaccination, near to the community, and we are also continuously trying the awareness into the slum areas also, because we have seen that the uptake of vaccination is little less in the slum areas. So we are continuously having a community participation through the NGOs, through the awareness for the slum laborers for participating in the vaccinations and take the vaccinations. So it was very important to motivate the people to come forward for the vaccination. And involving all the public representatives, involving the local councillors as well as the NGOs, CBOs and the community is an important aspect, and there is continuously this has been undertaken by the teams which is working at the ward level. As I said earlier, that we have 24 wards which is being led by the assistant commissioners and medical officer of health, and under them there are again teams of every health post and dispensaries which are working very hard to bring this, because they are the one who implement in the grassroots all these activities. So there is continuous efforts of coordination which is going on from the top to the bottom, which has been happening to review the situation continuously. Now, it is important that while we are doing all these activities, to continuously give the messages and the information to the citizens, as the misinformation is the one which is very, very critical. And to eliminate that, we have used effectively the social media. We have our Twitter handle. Every day the press notes are issued. Every day the feedback information is given. If there are any wrong information which is circulating through WhatsApp, it comes to our PRO department and we immediately give the clarifications. And regular informations and interviews and videos have been circulated through our senior leadership, as well as the Honorable Mayor is very active on our public representative, and they go in the community and they motivate the staff and also give the correct information to the citizens. And last but not the least is the governance and the leadership of all. The political leadership, a strong support has been provided by all our political leaders. There is a unified command system in Mumbai, so there are certain aspects which is centralized, but there are a lot of aspects which is decentralized. So some of the part which is centralized and decentralized decision makings which is happening. There are administrative decisions, there are operations which is happening at the field. So ward officials has been empowered. There are decentralized and delegation of financial powers which has been given to the ward officials. Then there is team development. There are multiple teams which is working. So it is very important to give the roles and responsibilities to be defined, exactly the SOPs to be given to these teams. The silos has to be broken, and empowering the field staff which has been done. especially the HR motivation in terms of incentives, in terms of payments is being done on the time. Effective coordination and clarity of roles and responsibilities of the various teams, and implementing the legislative measure. I think Mumbai has been successfully ensured that the mask has been used by the citizens, and for that we have both awareness as well as now we have legislative measures. Mumbai was the first city to start in the month of May 2020 fining the citizens, and we have around 200 rupees fines for the citizens, and so far we have collected around 50 crore plus and in the fine. In addition to this, we have some of the FIR which has been launched against those individuals who do not follow the break the chain transmission orders, where the super spreader events has been prohibited. Also, the restaurants and the malls. There was continuous monitoring of the patients also in the societies. There were patients who violate or the flaunt the rules has also been the action taken. So these are some of the measures to ensure the COVID appropriate behavior has been instituted into the system. So if I have to summarize the overall response of Mumbai model, I would say that it is the commitment of the top leadership, collaborative partnership, vision, and a sense of ownership. This all have worked together, the health and the non-health players together working very hard, and clear communications with the media and also involving the grassroots staff has all worked together and helped us to control the second wave, and we are very, very hopeful that the third wave which will come, and based on the experience of the second wave, we will be also able to manage the third wave. So thank you very much for having this presentation and listening. So I will take the questions maybe at the later stage.
Thank you very much for that very enlightening presentation. I think the heart of your presentation was your last slide. If you look at the Mumbai model, which we have talked about since the morning, it's been much celebrated across the country. I think it's largely about governance. It's not so much about a medical response. It's about a governance response, bringing everything together, making sure your supply chains are intact, and a huge degree of decentralization of governance. The second important part is the agility of response. And I suppose that the leadership support and the empowerment from the chief minister's side are the two key areas that have made that happen. And the third part, which is very important to my mind, is a huge degree of digitalization. Now, we already know that Mumbai is one of the most computerized municipalities in the country. You've been one of the early starters. And you have a unified control and command structure, as you mentioned earlier. We've seen that examples of that in the past as well. So my idea of inviting Mumbai to this conference was what is it that we can learn from your governance, agility, and digital model? You also mentioned about use of technology to communicate with people, which was incredibly important. To have this conversation with you, we have Mr. Sujit Patheja, who's Director Smart Cities and Urban Governance at SAP. In his own right, he's also helping us. We have the CEOs Association for Inclusive India, and SKOCH Development Foundation, and we are doing a nationwide study on connected states and connected cities and how do they deliver governance better. So to that extent, I think the Mumbai model is extremely important to be documented, to be taken note of, and just in case there are, a few things that you could possibly do differently or do better. Maybe that's a take back even for Mumbai from other cities, because we have so many other cities also who have done a reasonably commendable job in handling their COVID. So before I ask Sujit Patheja to intervene, I just wanted to understand from you, Maharashtra has a separate health system in IT. It has this health management information system, HMIS. So that's on one IT system, whereas all of municipality is on SAP. I don't know whether there's. So how did you bring that together? And is there any idea of bringing it all together and making it one unified command? How manage that? Or you felt that the governance part of it was as important as the health part, and it was better not to mix the two and let the medical part do its own job, and the governance part play its incredibly important role. That would be the opening question before I invite Sujit to speak.
So, question is to me, right?
Yeah, question is to you.
Yeah. So, see, we have our internal reporting system. The IT system, we have an IT cell, and we have one is the SAP system, which is there. The SAP system is used basically for all the other functions of the city, like licensing and so many and so forth. For the health related data, we have our internal like software which we have developed. And initially the things were happening on the Google spreadsheets, but then later on we shifted to a software. And this software has communication, like we can upload the data directly to the ICMR portal. Now, as far as the state is concerned, we send all the data to the state through the same system. And the state again, there is reconciliation and there is a sharing of data between the two systems. So we do not have, the same system as a state, but there is a continuous sharing of the information between the state and the municipalities. And there is this, NUHM has this IHIP portals, there are so many other various portals on which the other programs has been already, the reporting system is going on. So actually the need of the hour is to have a unified system. I would really, endorse that. During the pandemic, it becomes so difficult to collect so much of data and then, shift it to, because we have to send the data to the state, we have to send the data to the central system, and then we have our internal so many units. So it becomes very difficult to collect all this data, and I would really like to have this unified system where the system speaks with each other. Like if I have to upload the data from Mumbai to a national portal, it has to allow me. And these all has to be seen before, such kind of pandemic. And right now I see that there is not a very clear-cut systems which is established yet. But we are trying very hard so that we have a one unified, IT system. I think you are rightly pointed out that there are different systems of, IT which is existing, and there are efforts to have, some kind of integration and some kind of communication between the two systems, which will then lessen the time spent on this, by the staff.
Thank you so much. So with that, I think it's the entry queue for Sujit Patheja. We are right now discussing the third wave. I don't know if at all there's going to be a fourth wave or the first wave of a new virus.
Absolutely.
And what is incredibly clear is the role that IT systems and the unified command and control center is going to play. Also, the fact that a large amount of this problem is a supply chain problem. So even if the health system is there, but the oxygen is not there, or the medicine is not there, or the truck is not moving, or the hospital bed, what is available, what is not there, then how does anybody function?
Absolutely.
So from a digital perspective, if you could bring in, can CEOs Association bring something to the table and visualizing this and give some answers as to how do we bring the whole thing together? And also is an incredible part that I wanted to ask you is dialoguing with the citizen. Like you use social media, but social media can be fairly one way.
Absolutely.
How do you gather their felt needs? I mean, how do I communicate? This is what I want.
Absolutely. So I think, yeah. So Sameer, very
And also ask some questions. It would be very good.
absolutely. So I think some very, very pertinent points, Sameer, that you mentioned, and Dr. Daksha, first let me congratulate two of VMs on the wonderful response that you guys had for COVID. And let me say this at the outset: there is no replacement for human effort. No amount of technology can replace the kind of human effort that was required to tackle went through and possibly will go through. But Dr. Daksha, to your point that you mentioned, let me start by taking an example, very, very small thing. You mentioned about creating centers, creating more beds, tracking the availability of beds, and some of the other elements like oxygen supply and so on and so forth. As SAP, we are already managing the entire asset that is owned by MCGM, whether it is a building, land, or for that matter, something as small as a hoarding. Now, if the two systems that we talked about, a health system and an asset and the existing asset management, if both of them talk to each other and work together, probably your effort to identify new areas to expand your capacity to address or to put up beds, or your capacity to respond to citizens' calls through sending out ambulances at the right time, ensure that the ventilators and other devices are working and properly maintained at all the times. Your capacity to do that will increase. I'm sure you're already doing that through human effort, but your capacity to do that increases manifold when you're doing it through a integrated system. So I think that is the role of technology in all aspects. It is to augment the human effort and increase the effect of that human effort manifold compared to whatever you have done so far, and which is admirable in itself. But there's always room for doing more, room for an improvement. So I think that is one point that I would like to bring. The second important point, and very interestingly, you mentioned about an IVR call, and I have I have friends and family in Mumbai who were affected during the second wave. And again, an amazing initiative. Not only, I think this has also now been replicated by Government of India and some of the other states, where they are reaching out to the people who have been tested positive. But one element that I have, again, because of the human intervention part of it, what I have realized is a lot of people got calls even months later, after they had tested positive, right? So, even my wife herself, she got a call 1 month after she was tested positive. So what that does is, while the intention is very much there to engage and talk to citizens, but what the human intervention part does is it delays the whole thing, because that is the kind of scale that we are looking at. India is a big country with a huge amount of population. So, it becomes very, very important that we utilize technology in the right way to reach the right set of people at the right time, and hear what they are saying at that very moment when they actually need it. So I think that is the other aspect that that is important when it comes to technology. That is listening, analyzing, and acting on what your citizens are saying. So those are the two aspects that I feel, Samir, to your point, those are the two aspects in whatever Mumbai has done. If we add these two elements as well, I think our response to this pandemic, or for that matter, any other new pandemic, would be way more better and be way more effective than what it is right. So I really like to hear Dr. Daksha, what I said, is there is there some relevance to that? Do you think that this is a learning that you had as part of your response to the second wave?
So thank you, Sujit, for those suggestions. I think definitely these are welcome suggestions. And let me just little this thing that we have these dashboards which we have developed. So we have a very well developed our disaster cell, and they use this DI system. So they have their video analytics already existing, and they also have a dashboard which they had initially created for the bed management. We also later on created this dialysis bed, because we realized in the first wave that the dialysis patients are the one who are most affected. So especially for all those dialysis patients in the city, a special dialysis dashboard was created with the help of the nephrologist. I think that was also one of the very well, deserved model which we have developed. And then is the cemetery model, because there was, a lot of dead bodies which was waiting at the cemeteries during the month of May. So we thought that we should also have a cemetery dashboard. So now we are almost developed it. Initial also we have piloted it. Now all these, IT is a very big thing. Now basic issue, I would say that not only in Mumbai, everywhere in India, is you have to feed in the data into the system. So the issue starts with that. You have to train and sensitize your staff, because you are very busy. The hospitals are busy, and to put those data into your system. Now there is a central government portal, then there is a state government portal, and then there is a Mumbai portal. So my vision as a health officer or as a public health person is that we should have some kind of changeability or sharing of these data. Yes. And we should allow, suppose the city has developed a system, let's say Maharashtra has developed, or let's say Delhi has developed. How do you, seamlessly transfer this data to the other portals, whichever they require the information? So we should not struggle in Excel again to, upload those data. So as you rightly said that the SAP system could be utilized. So there must be many more platforms which I may not be aware.
Absolutely.
And we are into, planning this HMI system where we already have the pilots which is done, and we are developing this HMI system for the hospitals, which includes all the modules of, your procurements, your ventilators, ICU informations, and your all the stocks. Stock position is as important, like all your medicines which comes into it. But for that, you have to sensitize all cadre of staff to start using your IT systems. You have to make them, realize that this is the system which is going to help you. So sometimes there are struggles, to do this. And then you have also mentioned about, I think, another suggestions was the IVR calls. Yeah, so user friendliness of your system is also very important. Not every time your system is user friendly, so the people, they don't want to use it, and especially the doctors, I've seen that they avoid using the system. It takes hell of a time to convince the doctors and nurses to put the things and data into system, and everybody struggles on that. I think I will go on. The next point is about the IVR calls. What we have done is we have hired this professional agency who are there, the call centers, and we send them the line list, the positive patients line list data to them. And sometimes what happens is patient is not given a correct phone number, which gets updated later on. Probably, that comes in the system after. Maybe your wife has received a call. Apologies for that. But we have seen that, even in updating the phone numbers into the system, it takes a lot of time, because once you call the patients, you come to know this is the phone number. And I'm not saying this could be the reason, but there are multiple reasons where the patients also do not give the correct information in terms of addresses, in terms of the phone number. Then the data goes to the call center guy, and he will
Thank you very
start
much.
the idea calls when it gets,
Very interesting conversation. We may possibly, if you'd like, we'd love to set up a separate discussion with you on what are the possibilities and how, maybe we could all come in through our distinguished fellows, through our association, etc., help you document what you have achieved, and maybe help you articulate your own vision a little better. With that, since we are behind schedule, I'll request Dr. Ramachandran, sir, a governance response on all of this. We've discussed technology at length. Dr. Ramachandran?
Yeah. Yes. First, a couple of observations. The first point I would like to make is Mumbai is a case by itself, and Mumbai has certain advantages also. I mean, international focus is on the city. Of course, the national focus also is there. And it was, the reporting was not very good, as I said at the beginning of the last year. But Mumbai has the advantage in the sense that the municipal commissioner is one of the senior most officers of the state. That itself is an advantage, but he has to be a leader also. And the rapport with the state government is much, much more closer as far as Mumbai Corporation is concerned. Of course, Mumbai Corporation also has the command over resources, because it can manage very many things on its own. So these are positive factors. And as I said, the leader has to be able to lead. And that is when the change happened last year. The leader's capacity got shown, and that's how a difficult situation was controlled. That's important. The second point is, I don't know whether we have time, but what is important about Mumbai also is, if my information is correct, Mumbai has close to 50% of its population living in slums. And Dharavi got highlighted. Yes. Handling the slums, and especially handling the toilets which were repeatedly being used by people, was a big challenge for Mumbai. And that was addressed in this whole scheme of things. And you can imagine there are no immediate quick fix solutions as far as slum dwellers, large number of them using one single room, and they having access the common toilet, and the issues which come out of that. I'm sure my doctor friends would confirm this point, that I believe there is also a theory that COVID could spread through toilets also. So that was addressed in a very focused manner, repeat cleaning of toilets and things like that. That's also important as far as Mumbai is concerned. One question I would have for Dr. Daksha is, how did you handle the feedback you received? I'm sure there must have been a constant flow of feedback from people as to what their concerns are, what their problems are. How did you analyze, respond to them? Because that's also important for other cities. It's just not enough to say that we have done all this, everything is fine. There is another side to it. And Little bit I have been observing some senior citizens have been finding it difficult to get appointments for vaccination. They have to repeatedly try to approach people. Whom do they approach? Then you cannot just go and stand in line for hours. That's also a problem. There has been talk about this door-to-door facilitation, but I don't know whether that can happen taking into account the storage requirements and things like that. Also involving other voluntary bodies. I saw in a hospital in Mumbai, one of the clubs, the social service clubs, they were actively managing the vaccination facility in the private hospital. These are all possible in Mumbai, but in the larger sense, I think that part of communication where people feel concerned and they get frustrated because they cannot get immediate answers. How is that to be addressed? That would also become for the next wave. And also to repeat the point I made to Haryana, what is Mumbai's appreciation of what is it going to be as far as if there is a third wave, what its dimensions are, what additional action preparation is being done by Mumbai. Again, a lesson which probably others could take, because these are all learning processes at this stage. Thank you. Back to you.
Okay. Before you answer that, Dr. Daksha, may I also ask Shefali Dash. Dr. Dash, you also come from a technology background, and a very important point that Dr. Ramachandran made is that how do you take note of citizens' concerns? How do you know what you're doing is working, not working? How receptive they are to it? Could you be doing anything better? Because, sitting in your headquarters, you may think that you've done the optimum, but that service is not reaching. So what is the survey mechanism? What is the feedback mechanism? Do you think such a mechanism is important? And if you have any question related to that you may want to ask, Dr. Dash.
Basically, what I feel that they, as a part of Smart City, very smartly, they have established a control command center, CCC, which is quite efficiently working. That's what we hear from all the presentation we have been hearing for observing for the last 1 year. So that way, Mumbai probably has a better advantage because their CCC is working very in a very organized way. That is number one. But what I would like to ask them is, since you have done this activity in a very detailed manner, we can see from the presentation also you have cut down all the steps into very minute detail, small steps, and assigned responsibility to a person or a team or something to handle each of them. So that is why your coordination becomes much easier. That's fine. So you have done well, and that's what past experience shows, that you handle the second web quite well. So that means your procedure is fine. What I would like to ask you is, you are probably fortunate because you do have technology at your command, you do have manpower at your command, and you've got a lot of private hospitals who have come and join hands with you. That's a bigger thing. When we take it down to the rural areas, which we feel probably the third wave will be harder, how will they able to handle this with the constraints they have in the rural areas and the facilities which you are having in your place? So how do you think it can be scaled down by using technology? Maybe one way, but any other governance pattern, like Mr. Ramchandran says, can it be, can you put some light on this?
Okay.
So thank you for the question.
Yeah, half an hour behind. Huh? Thank you so much.
I'll just be very quick. First question is about what is your feedback mechanism? Like if any grieving citizens has this. So one is our command system. Of course, at the central level, we have this, anybody who calls 1916, there are option of, if you want to register a complaint. This complaint is then escalated to the concerned department and the officers, and they have to, answer those queries. Second is our Twitter account. Anybody who tweets, we ensure that if there are questions or if there are guidelines which has been asked, it is immediately answered within some time, because the Twitter team I was handling earlier. And we also put our all press notes. Like suppose tomorrow we are not having a stop, or suppose tomorrow we are not having a session in some one particular center, we put all those details that tomorrow at 3 o'clock the center is going to start, or tomorrow these centers are not going to work. So everything we are putting on Twitter, and we have also press notes. The media coverage is extensive. You will see the Times of India and all major and minor newspapers which covers that, all these details which we put it in the media. So media was really used for giving the informations about the vaccinations. Now the question of, certain section of populations like elders, or some people who do not have mobile, how do they reach? So So we have our local help post. We have created groups. We have local councillors, as I said. So the public representative in the local communities are very active. We have taken enough number of sensitizations of the local councillors and their volunteers. So the volunteers has been also been, in every sections are active to take care of the senior citizens who have so many queries, who may not get the slot. But we have made it easy for them that the second and the first dose for anybody above 60, it should be, walk-in vaccination. So as far as these informations is concerned, this is available at the local ward and the help post level. And in the slum areas particularly, as I said, the use of and the help of the NGOs and the CBOs has been extensive. The many volunteers of the NGOs and CBOs has been encouraged to partner with us, especially in the vaccination drives, to help the senior citizens. Like we have so many centers where the senior citizens find it difficult to get down and go up to the center. So we have provided some wheelchairs for them and so many good facilities over there. So these way, different mechanisms has been used to give the support to the senior citizens. And as far as, madam, your question is concerned, like in the rural areas, how do we go about? I would say that the rural areas, the only key would be the community participation and empowering the community and the community leaders, because I think that these are the ones who are in the grassroots, and every family, if we can identify someone or a youth, a group, because there are many people who are voluntarily, and even I get a lot of calls that we want to help. Like there are any number of people who wants to help the government. That's what we have realized. And it is that sometimes we fail to channelize those energies and those help from our side. So we need to take and identify each and every group or the community, section where we can assign certain responsibilities and duties to them. So I think with this, messaging system to the community correctly, even the smartphones are not available, but a simple messaging system can be established.
Thank you very much for sharing that with us. Indeed,
just one point, if I may take 30 seconds to make one small point on what Dr. Ramachandran said and what Dr. Daksha responded. So, ma'am, what we have seen is when it comes to communication, I think all cities do possibly a wonderful job of communicating their procedures, policies, etc. I think the point Dr. Ramachandran mentioned was not just communication; it is also about getting the feedback or perception. While we respond to grievance, it is the perception that is unfortunately missed out. Why do people not want to take vaccine, or why do people not want to maintain COVID appropriate behavior? It is a function of perception, not a function of grievance. So I think that is an area that cities should, as we move forward, should focus on in capturing that perception and feedback in terms of why people are doing or behaving in a certain way, or why are they not responding to the calls of appropriate behavior or whatever. So that, I think, that is the area that all cities to now look to prepare, because third wave, fourth wave, fifth wave, we have no idea how many waves we are going to see. It is only through our behavior and this culture that we will develop, a social nudge sort of a thing, is what is going to help us. And that happens when we start understanding the community, understanding individuals and their perceptions, not just communicating our thought process to them.
Just a quick feedback. We are doing a focus group discussions for this, especially for the vaccination and especially for our COVID appropriate behavior. So we are just organizing that with the help of UNICEF in all levels of community, like slum, non-slum, and even the floating populations. Like, what do they think about this measures? Whether they understood it. So this focus group discussions and the feedback mechanism, we are actually into this process right now, as you rightly pointed out.
Yeah.